Good afternoon, everyone, and welcome to the Next Generation Supply Chain Speaker Series. I am the director of this series. Today, we are really fortunate to have Karthik Natarajan from Minnesota. For more than a decade or so, Karthik has done a lot of work in the area of global health supply chains, humanitarian operations, so on. Today, he's going to talk about one of his projects on healthcare supply chains for contraceptives in underdeveloped countries in Africa. Okay, Karthik.
So, can you all hear me well?
Yes.
Okay. So, first of all, thank you for being here, and thanks for taking the time to attend this talk. So, the work that I'm going to present today is related to distribution strategies, sort of supply chain distribution strategies within public health sector in developing countries. So that's the context in which I'm going to talk about. So it is going to be about supply chain distribution, looking specifically at the public health sector, and it is going to be in a developing country context. Okay, so that's sort of the context for this presentation. And this is actually joint work with Amir Karimi, who's now at UT San Antonio, and also a couple of my Carlson colleagues, Anant Mishra and KK Sinha. And one thing I want to say is, I designed this talk to be interactive, so don't feel like you need to wait until the end to ask questions. So feel free to ask questions. Happy for this to be an interactive presentation. So I intentionally kept it to 45 minutes so that we can have a more lively discussion. Okay, so the motivation for this presentation actually comes in the context of the UN Sustainable Development Goals 3.7 and 3.8. Just want to make sure, because we have a diverse audience, how many of you are familiar with the details of UN SDGs? So maybe you've heard of it, you don't know exactly what goes into it. So essentially, if you look at SDG 3.7, basically what it calls for is universal access to sexual and reproductive healthcare services. So that is SDG 3.7. And a connected SDG is SDG 3.8, which calls for access to safe, effective, and affordable medicines and vaccines for all. So again, there are multiple different SDGs, so some on the environment, some on health, and so I just want to preface this by saying that ours is more focused on the health SDGs and not on the other ones. And specifically, these are the two that are related to our work. Okay, so the goal for setting these SDGs is typically, the way they do this is they have a year target. So by 2030 or 2035, they want to achieve certain goals, and that is the reason for setting some of these metrics, right? So what you see here is how countries are performing in terms of meeting those goals. Okay, so what we see here is there is a wide variation. Okay, so the lighter the color means that they are much more closer to the goal, and the darker the color, they are more farther away from the goal. Okay, so what we see from this map is that there is actually a wide variation in terms of how countries are performing. And also, another thing that you will see is that several countries are lagging behind. So you see the darker colors, those are the countries that are lagging behind. Okay. So for example, if you look at Africa, especially if you look at countries within sub-Saharan Africa, they have about 30 to 40% unmet need for contraceptive methods. Okay. So why this is important is because in terms of a global scale, this translates to about 190 million women of reproductive age who don't have access to the contraceptive methods of their choice. Okay, so this is closely tied to, again, the SDGs 3.7 and 3.8. So the goal of this work is, can we do something so that we can sort of bridge this gap, right? So can we get countries closer to their SDG goals? Okay, so that is the main purpose of this work. Okay, so the natural question that arises is, what is actually stopping countries from progressing towards these SDGs, right? And there are many different reasons. So I'm going to bucket that into sort of two different buckets. So the first is what we call as demand side barriers. So even if supply is there, oftentimes there are demand side barriers because of which people actually cannot access these services, right? And that includes, first of all, lack of awareness. So I don't even know what the benefits are, so I'm not going to seek the services that are being offered, right? So lack of awareness. The second is in many cases, people have to pay, so affordability is definitely a concern. And then the third one is, how do I actually get to the health center? So lack of reliable transportation options, right? And all of these are barriers that can happen on the demand side, okay? And then if we move on to the supply side, again, there are numerous barriers on the supply side. So one is poor quality. So healthcare is available, but it is not of the quality that patients want, so they actually prefer not to even go to the healthcare center, right? So poor quality is a problem. And then in many cases, limited availability of healthcare providers and services. That is also a problem. And then finally, stockouts of essential health commodities at the last mile facilities, okay? So this particular aspect, the stockouts of essential health commodities at last mile facilities, that is going to be the focus of the work that I'm presenting today. Okay. Very well acknowledging that there are several other barriers, but this work is going to focus on what is happening at the last mile facilities and what can we do about reducing stockouts at those last mile health facilities. Okay, so just to give you some background context, what I thought was it might be useful to start with the structure of public health supply chains in developing countries, right? Because many of us have not been in these countries, so we don't know what exactly the supply chain looks like. So I just want to provide some background context in terms of what these supply chains actually look like. Okay. So essentially what happens is the health products first enter the country at the national warehouse. Okay, so this is where all the products enter into the country. And these are all public health facilities. So these are managed by the governments. So we start with the national warehouse, and from there, the products go to the regional warehouses. So there are multiple regions, and it goes from the national warehouse to the regional warehouses. And from the regional warehouses, it goes to the districts, right? So that is the third level in the supply chain. And from the district warehouse, products go to the last mile health facilities, okay? And this is the touch point for the customers. So this is where clients actually go to access health products and services, okay? So what is the main challenge here? So the main challenge, if you look at public health supply chains in developing countries, it is the stockouts of reproductive health supplies and other essential health commodities at this point, okay? So the reason I'm focusing on this point is this is where it actually interfaces with the customer. And oftentimes what you will also see is products are actually available at the national level. Products are available at the regional level. But the last mile is typically the most challenging part. So oftentimes we see stockouts at the last mile facilities, even though the supply chain is doing well before that point. Okay, so that is the reason why we focus on the last mile facilities. And in fact, stockouts are a widespread problem across number of countries, right? So, and it doesn't depend on continent. You go to any continent, there is a lot of countries where stockouts are a major problem, right? So for example, Haiti, Senegal, Nigeria, Kenya, Pakistan, Indonesia, in all of these countries, stockouts are a major problem, okay? So what is surprising is even basic contraceptive methods like condoms, which we typically take for granted, those were out of stock in nearly about 40% of the facilities, okay? So this is the simplest of the contraceptive methods, and those were out of stock in 40% of the facilities. So imagine the more complicated ones, which also require interaction with a healthcare provider, and the problem is even more acute for those types of contraceptive methods. Before I move forward, I want to pause to see if there's any questions. Okay, so let me dig deeper to give you some, to give you a sense of how the product is actually distributed within these supply chains. So I showed you the structure, but now I want to get into how the products are actually distributed within these supply chains. Yes, sir.
Before going ahead, I have a question. You mean that in the healthcare supply chain, firstly, we have warehouses by state and then cities,
Mhm.
and after that it's going to client?
Yes.
United. Okay, because
Yeah.
I want to make the framework.
Yeah, so if you think of the US context, right? So think of the national warehouse, pick a location. It might be in DC or it might be, let's say, in New York, right? So that's the national warehouse.
So they distribute.
Yeah. So from there, they distribute to the states. From the states, they distribute to the individual counties. And then from the counties, it might go to different health clinics.
Under the county, it is governed by government.
So all of these are government facilities. So the whole supply chain is actually managed by the government. So these are public health supply chains. So there are private parties involved, for example, for logistics, but the facilities themselves are actually government facilities. Yeah, and the reason is that it is a big component of the health system in many developing countries, right? And this is where governments actually have some power to make a change, and they don't have much control over the private sector supply chains. So this is more focused on how do we improve public health supply chains that are managed by governments. Yes.
Can you repeat that one more time? Where you said the government takes it in, right?
Uh-huh.
And they distribute. What do they do next? They distribute it?
Yeah. So, for example, what happens is, so every country has a Ministry of Health, right? So the Ministry of Health is the one that actually places an order, buys these health supplies, and it first comes to the national warehouse.
Okay.
And yeah,
That got it. I was missing that piece.
exactly. So it's all handled by the government, including procurement, managing the supply chain, and so on.
Thank you.
Okay, so let me get into how the product actually gets distributed within these countries, right? So if you look at public health supply chains, the most commonly used distribution strategy is known as a pull distribution model, okay? So essentially, under a pull model, what happens is, so there is a health worker who is at a last mile facility, okay? And what you're going to see is this health worker actually performs many different roles in addition to providing care, which is their primary responsibility, okay? So under a pull model, what happens is the same worker who provides treatment also is responsible for keeping track of inventory on these stock cards, okay? So that's their additional responsibility. They have to keep track of every single type of health supply, how much do they have, when to order, that's all part of their responsibility, okay? On top of that, they have to place orders with upstream facilities. It is the same health worker's responsibility as well. There is no separate logistics manager that is sitting and placing these orders. The health worker also does that job. On top of that, they are also responsible for transmitting whatever information is on this card. So the inventory consumption data, they also have to transmit that information to the upstream facilities, okay? And it could be as simple as taking this card, going to the upstream warehouse, and giving it to them, right? So this is a pretty tedious job. And then the last thing is, once they place the order, they are also responsible for actually going and picking up the ordered supplies from the upstream facilities, okay? So there is all these different supply chain tasks that health workers do on top of the main job of providing care to patients. Okay. So essentially, under the pull model, what happens is health workers are responsible for inventory management and replenishment on top of their primary job, which is to provide care to patients. Okay, so where does this fall apart? The reason it falls apart is because health workers are not trained to do inventory management tasks, right? So they receive some basic training, and then they are tasked with managing this entire supply chain. And this is where they are not equipped to actually do these tasks. And because of that, what happens is it actually increases the potential for supply-demand mismatches at the last mile facilities. Okay, so this is the crux of the problem. Okay, so what did countries do?
Karthik, just
Yes.
a question. When you talk about supply-demand mismatches, is it like more supply, less demand, or the other way around, or you're talking about both? Which one do you see is more?
Yeah.
Prevalent?
It's more on the stock out side.
Yeah.
So the reason is because like if you're not keeping track of this information, what is going to happen is your stocks are going to run low, and then you're not placing orders on time, right? And then even if you place orders on time, because you actually have to go and pick up the supplies from the upstream warehouses, what happens is if I have more patients on any given day, I'm just going to focus on that. I'm not going to spend time going to the city to get these supplies from the upstream warehouses.
And did you find any regional variation in terms of, are there any pockets where there is excessive supply but low demand kind of a?
So excessive supply, we did not find a problem. I mean, I want to say not in a wide scale,
Yeah.
but with excessive supply, what can happen is the products can actually expire,
Yeah, that's the thing.
right? And also what happens is sometimes, again, you have to keep track of that information on this card. And if you don't track it, you might be giving out expired products, which again compromises on the health outcomes, right? So there is multiple problems if you don't keep track of information. Okay, so this is where countries said, maybe there is a better method to manage the system. Instead of asking health workers to do all these tasks, maybe there might be a better way to do this, right? And this is where a different distribution strategy came into play, which is known as the informed push model. So the previous one was called as a pull model because health workers are actually pulling supplies through the supply chain. In this case, somebody else is going to push products through the supply chain, okay? So how does this model actually work? So under the push model, what happens is, think of a third party. So think of like a 3PL, third party logistics provider, who is actually responsible for delivering health supplies to last mile facilities, right? So think of this as a van that is coming in every week, loaded with supplies. They will check your inventory, and then if you need more, they will actually deliver to the facilities, right? So health workers are not doing their job. There is a van that is coming every week and delivering supplies. And on top of that, what they also do is, when they come to visit the facilities, they actually will go through these inventory cards and make sure that that information is accurate with the number of products they have on the shelf, right? So they can look at the products sitting on the shelf, they can look at the stock cards, and then they will make sure that these two are actually matching, right? So they're also focused on increasing the accuracy of the data that they have. And then finally, what they also do is they take this information, upload to an electronic system, and transmit that to the upstream facilities. Okay. So basically, what is happening right now is the tasks are clearly delineated, right? So health workers only focus on treating patients; they're not dealing with the inventory stuff. And then the third party is responsible for data collection and transmission, and they're also responsible for bringing the supplies to the health facilities. Okay. So why is this good? Because now health workers don't have to focus on managing inventory. They don't have to go upstream. So they are relieved of all these responsibilities. So this in turn could alleviate some of the challenges faced by health workers under the pool distribution model. Okay. Any questions? Okay. Yes, go ahead.
Well, it's still fundamentally a pull, though, right? So you're not doing, unless you're doing centrally coordinated planning from the national warehouse and then deciding where to put it. You've got a third party, 3PL, essentially more of a large company model like you would have with a McKesson.
Right. Absolutely, you're right. So this is not a full-scale push model. It's push pretty much at the last mile level, right? The upstream is still operating under a pull model. So the regional district gets from the regional gets from national. So that is all still a pull model. But basically, their thought process was, it is the last mile facilities that are struggling to do some of these tasks. So maybe by doing the push, we can relieve them of some of these challenges. That's a good question.
And relevant to that, if you have push model just at the last mile and pull. So what upstream impacts does it have? I mean, you have largely a pull model and push at the last mile, right? So
exactly. Yeah, those are great questions. Here we don't look at what happens about the district warehouses, but that's a good question. Yeah. Okay, so at this point you might be thinking, this all sounds great. I mean, we have solved the problem because somebody else is doing inventory management. This should definitely help out. Okay. So the reason this is not straightforward is, yes, it has a lot of benefits. So it has the potential to lower supply-demand mismatches, but the main problem is that it is much more expensive to operate, right? Because there is several startup investments. So you have to buy the vehicles, you have to do route optimization, and then on a daily basis, you have to pay for fuels, per diems, and all of this, right? So it's not clear because there is a lot of upsides, but it also comes at a pretty steep price, right? And this is where it can be challenging for developing countries because they don't have that kind of money to invest in these initiatives, right? So this is where we come in and say, can we actually identify when these kinds of initiatives are more effective, and also can we identify when these are not effective, so that we can be much more strategic in terms of how we allocate limited resources, right? Because what you will see is that you shouldn't be rolling out these kinds of interventions at every facility. That is not a prudent strategy, and you will see that at the end of the talk. So what you will see is that we identify specific types of health facilities where it's going to be super beneficial, and then we will show a set of facilities where this is actually not going to be beneficial, right? So essentially, this will be more of a resource allocation model, and trying to understand what is the basis for that allocation decision. Okay, so essentially, given this discussion, I want to formally lay out our research questions. So the first question that we ask is this is a baseline question. Is this even effective? It sounds great on paper, but we want to make sure that it is actually effective, right? So that is our first research question. Does a transition from the pull model to the informed push model reduce the likelihood of stockouts at last mile health facilities? So this is a fundamental question that we ask. A related question is, under what conditions is it actually more effective versus less effective in reducing stockouts? So these are conditions that we want to establish so that we can say, put the money here, but don't invest in these types of facilities. Okay. So the first two questions are more on the supply side. It's focused on stockouts, but we also want to look at how it actually impacts the patients because those are the ultimate beneficiaries, right? So that is our second research question. So second research question is, what are the public health implications of this transition in terms of how much clients are satisfied, right? Does that actually increase after this transition? What is the prevalence of contraceptives within the population? What is the impact on unplanned pregnancies, for example, right? So we also look at a number of public health metrics. And then finally, what we also look at, and this is the main purpose of this work, given the cost-benefit trade-off and the significant resource constraints, which facilities should actually be prioritized when transitioning to the informed push model? Okay, so those are the research questions that we look at in this work. Any questions? Okay, so what I'll do is we want to get to these research questions. So I'm going to build a framework that will help us get to those questions. Okay. So the framework that we propose is based on this logistics cycle framework that is frequently used by global health organizations. Okay, so it's if you look at organizations like WHO, USAID, they all use this logistics cycle framework. Okay. So there are 5 different elements of that. But for us, there is 3 elements that are relevant to our work. So the first is data collection. So that is simply keeping track of inventory information on stockouts. Okay, so that is what I showed you before. It's making sure that you are tracking inventory within the health facilities. Okay. The second activity is taking that data and then sending that to the upstream facilities. That is the data transmission piece. And then the last piece is transportation of health supplies from the upstream warehouses to last mile facilities. Okay. So what I'm going to do is for each of these activities, I'm going to describe how the push model and the pull model are different. Okay. So let's start with data collection. So under the pull model, health workers are responsible for keeping track of inventory information, right? But as I mentioned before, they're not well trained in managing inventory. And on top of that, they typically also keep track of inventory using paper-based records. So that increases the chances for errors. Okay. Going to the pull model, this is all done by the third-party logistics providers who are actually well trained in managing inventory because that is their primary job. And as I said, during the site visits, what they do is they look at these cards, verify the accuracy of the information, and they will make adjustments if they are needed. Okay. So essentially, the implication of this is that the transition to the informed push model could alleviate challenges related to data collection and accuracy at the health facilities. Yes.
So, do you know of any countries where they use the pull model at the last mile facility, but we're using electronic records instead of those paper records, and that reduces the stockouts?
Yeah, great question. I'm gonna actually show you how this compares to that. Yeah, that is actually the final piece of our work.
Yeah.
We do compare. Should you actually just invest in electronic LMIS rather than do a full scale change in the distribution strategy. And I'm going to show you where exactly that is an appropriate strategy and where you should go for a full scale implementation. Yes.
So pull model is equal to downstream model or not? It's upstream.
So everything here is just the last mile facility. So it's only the downstream, the last point. The main difference is under the pull model, the health worker is basically asking upstream facilities, give me this number of whatever health supply it is. And then once they are ready to ship, they actually go and pick up, right? In the push model, that is all done by the logistics provider. So the health worker is not asking anybody. They show up with a van, they look at how much inventory you have, and then they will fill your shelves. Okay. So the second piece is data transmission. So under the pull model, the paper-based inventory and consumption reports are sent to the upstream warehouses, and this is done either by mail, so they literally will mail it to the upstream facilities, or they might actually physically take it to the upstream facilities. Okay, and as you can imagine, this can be hugely time-consuming, and what it means is it hampers the timely transmission of critical supply chain data. That data is not getting to the upstream on time, and that can lead to supply chain challenges. Right? Under the informed push model, it's all pretty simple. The logistics providers, when they come to the sites, they basically upload all of this information to an electronic system, and then it gets sent to the upstream facilities. Okay. And then the last piece is transportation. So under the pull model, health facilities are responsible for collecting the ordered supplies, which can be challenging because sometimes the roads get flooded and you're not able to go to the upstream facilities, right? Or you don't have a dedicated vehicle. You might have to take public transport to go and pick up the ordered supplies. So all of these can create replenishment challenges. Under the informed push model, none of those problems exist. The logistics providers show up at the facilities and then they deliver supplies on a regular basis. Okay. So essentially, the transition to the informed push distribution has the potential to alleviate challenges related to timely data transmission and also transportation of supplies from upstream facilities. Okay, so given all these advantages, we naturally expect that a transition from the full model to the informed push model would lead to a decrease in the likelihood of stockouts. Okay, but as I mentioned before, it is capital intensive. So in terms of actual numbers, for example, if you look at Senegal, the cost of operating this distribution model is about 11% of the total annual spending on contraceptive procurement. Okay, so 10% of your health budget goes to just managing the supply chain, which is a pretty significant amount of money. Okay, So there is definitely a lot of benefits, but it is also pretty capital intensive. And so this is where we want to understand what are the types of facilities for which this is going to be beneficial, and what are the types of facilities for which this is not going to be that beneficial, so that we can be more smart and strategic in terms of how we allocate the resources. Okay, so when we think of facilities, so this is where we get into the details in terms of how we look at facilities. So we want to look at what facilities do along two important dimensions. So the first is what we call as Logistics Management Information System, or LMIS practices. So this is a terminology that is frequently used in the public health literature. So LMIS is basically the system that is used to track and keep record of inventory within the supply chain. Okay? And those practices can be more mature or less mature. And then the second aspect that we are going to look at is access to road infrastructure, which can be more developed or less developed. So think of a rural facility and an urban facility. So urban facilities will have access to good road infrastructure. Rural facilities may not have that access, right? So we want to understand whether these benefits are going to be different depending on whether you're a rural facility versus an urban facility. Okay, so let me explain this one by one. So let's start with LMIS practices. So LMIS, as I said, basically is a system that is used to keep track of inventory information. So it's literally, think of that stock card that I showed. So that's where you keep track of how much inventory you have, how much has been consumed, and how much have been expired, and things like that. Okay. So under the pull model, as I mentioned before, because they do this on paper, because this is done by health workers, inventory data accuracy is a big challenge, right? In many cases, the data is not accurate, and that creates complications for the supply chain. So for example, this particular paper, what they found was that if you looked at Nigeria, less than half of the sample facilities actually had accurate inventory information. Okay, so if you don't have good data, the decisions that you make based on that data, they're also not going to be that great, right? So that is one problem. And then the second problem is taking that data to the upstream facilities in a timely manner. And that is also a challenge because they use paper-based records, roads are not great, and you don't have dedicated transportation vehicles, right? So there is multiple challenges when it comes to LMIS practices. So to overcome these challenges, what the public health sector advocates is to follow two specific LMIS practices. So if you want to increase the accuracy and timeliness of data, they specifically suggest following two different practices. So the first thing that they suggest is to update the LMIS on a daily basis. So at the end of the day, take the stock cards, make sure you keep up-to-date information, right? So that has the potential to increase the accuracy of the inventory data. And then the second one that they suggest is to use electronic LMIS instead of paper-based LMIS. So what are the benefits here? First of all, if it's electronic, you can collect from multiple facilities much more easily. And then the second benefit is you can also transmit that information much more easily than just taking it on a paper and sending that to the upstream facilities, right? So what is interesting is the transition to the informed push model actually offers very similar benefits, right? The reason is during the site visits, the LPs actually verify the accuracy of the data, and then they upload this to an electronic system, which can be sent to the upstream facilities, okay? So given this similarity in the benefits, what we expect is if you're a facility that already follows one or both of these practices, then you may not actually benefit as much from transitioning to the informed push model. So our study prediction is that a transition from the pull model to the informed push model would result in larger benefits for facilities with less mature LMIS practices compared to those with more mature LMIS practices. And by less mature, what I mean is facilities that neither update LMIS on a daily basis, nor they use electronic LMIS. So these are the facilities that will benefit the most from this transition. Any questions? And I don't know if I'm moving through fast, but I just want to pause and see if there's any questions. Okay. So the second aspect that we're going to look at is access to road infrastructure. Okay. So again, under the pull model, the health facilities actually have to go and pick up the ordered supplies. And then on top of that, they also need to send the paper-based inventory consumption reports to the upstream facilities. And as I said, this is either done by mail or it is actually hand-delivered to the upstream facilities, right? And both of these activities can be challenging for facilities that don't have access to good road infrastructure. But if you're a facility that is, let's say, an urban facility that has access to good road infrastructure, these activities may not be a big challenge, right? So as a result, these facilities may not benefit as much from a transition to the informed push model. So that is our second study prediction. So what we predict is a transition from the pull model to the informed push model would lead to larger benefits for facilities that have access to less developed road infrastructure compared to those with access to more developed road infrastructure. Okay. So essentially what we're saying is if you're urban, you may not benefit as much. If you're a remote rural facility, you are more likely to benefit. Okay. Okay. So yes,
just a quick question. So, I mean, overall, do you think, I mean, the type of contraceptive also plays a role in this, whether it's a condom versus a pills? And
yeah, that's a great question. So, you will see, so our analysis is actually at the method level. So, it's not at the facility level. And the specific reason is, so there is multiple reasons for that. One is, if I want a specific type of contraceptive, I'm only going to look for that. So it's not a substitutable product that I can pick something else. And on top of that, what we also did was we have also done accounted for substitution. So for example, if you're looking for a long-term method and it's not available, you might be more willing to pick up a short-term method, but not the other way around. So we have also looked at those kinds of interactions, and all our results actually hold. Okay, so this is where we want to see whether all these predictions, those are great on paper, but we want to make sure that those predictions are actually true or not. Okay, so this is where I'm going to show you what data we used, what is the study setting, and then what are the results that we saw based on the data. Okay, so our research context is basically the reconfiguration of the supply chain distribution strategy in Senegal. Okay. So under 2011, the public health supply chain actually used a pull model. Okay. And the problem was that there were a lot of stockouts within the contraceptive supply chain. Okay. And for example, 30% of women had unmet need for contraceptives, and 70% of public health facilities had stockouts of at least one contraceptive method. Okay, so stockouts were a major problem. So this is where the Ministry of Health within Senegal wanted to come up with a comprehensive plan to address this problem, right? So basically what they did was they partnered with the National Supply Pharmacy within Senegal, an NGO known as Intra Health International, and then the Gates Foundation to develop this new distribution strategy known as the informed push model. So that is what I was describing before. And starting in 2012, they actually rolled out this initiative in a staggered manner to all public health facilities across Senegal. Okay. So what you will see here is there is multiple shades of blue. So if it is really dark blue, that means it was early rollout, and the lighter the shade, it's later rollout of the initiative. Okay. And so it was rolled out not at once, but in a staggered manner to all public health facilities. Okay, so what is the data that we use? So we have three different data sources. So the first is what is known as the Service Provision Assessment Survey that is collected by the DHS program at USAID. So this is publicly available data. So if you go to USAID's website, if you search for DHS program, you will find this survey data. So it's known as SPA, or Service Provision Assessment Survey. And you can find this data for a number of countries. So it's not just Senegal, but also for a number of other countries. So what the survey tells us is whether products were out of stock at last mile facilities. So that is one piece of information we use. The second piece of information is the DHS program's women and household questionnaires. So this gives us data on the demographics and socioeconomic characteristics within our target population, right? So what's the age of people within that area? What's their education status? What's the household income? All of that is coming from the second survey. And then the third one is, because we are looking at road infrastructure, we also used OpenStreetMap to collect road network data for Senegal and see where our facilities are actually located and what is the distance between the facility and the upstream warehouse. So that is all coming from OpenStreetMap. Okay, so let me describe our study variables. Okay, so our dependent variable is, we are primarily interested in stockouts. So that is the dependent variable for this study. So it is a binary variable that indicates whether or not a particular contraceptive was out of stock on the day of the survey visit. So essentially what happens is there are surveyors who go to the different facilities and they are looking at which methods are available, which ones are not. And if it is not available, they mark it as 0. If it is available, sorry, if it is not available, they mark it as 1. If it is available, they mark it as 0. Okay, so that is our dependent variable. Our main independent variable is informed push model. So this is also a binary variable that takes the value of 1 after the initiative is rolled out to that specific region. And then it takes the value of 0 prior to that. Okay, so that's our independent variable. And then we have two moderating variables. So LMIS practices and road infrastructure. So LMIS practices is classified as more mature if the facilities either update LMIS on a daily basis, or if they use electronic LMIS, or if they do both. It's classified as less mature if they don't follow either of those practices.
So the informed push model, you said it was not introduced all at once. It was like somewhere. Do you know how much of randomization was there? There might be selection in terms of which county they want to introduce.
Yes, you're spot on. Yes, there was selection.
Yeah.
So what they did was they actually first rolled it out to the bigger areas. So they wanted to target larger population centers. So the cities or the urban areas were the ones that first received the intervention, and then the rural areas got it later. So that's a very, very apt point. I'll show you, I'm going to control for that by using the population proxy as a control. Yeah, that's a really good observation. Okay, and then the road infrastructure is classified as more developed if the distance between the health facility and the primary road is less than 7 kilometers, and is classified as less developed otherwise. Okay, so the closer you are to the primary road, the more developed the infrastructure. Okay, and then we have a bunch of control variables. So we control for facility characteristics. We control for the type of products that are offered at health facilities. So the more you offer, the more complex it might be. So we control for that. And then we also control for client characteristics. So age, education, household size, wealth index, all of that is controlled for in our analysis. Any questions on this? Okay, so not very surprising, because this is an intervention, we use a difference in differences specification. And so I just want to point out a few things here. So we control for regions because it was rolled out to different regions at different times. So we have the region fixed effects, we have year and month fixed effects, and then, so Shrikar, to your point, this is the control for the population. And then beta 1 is our coefficient of interest. So we want to see what is the impact of the informed push rollout to a specific region. Okay, so these are our results. I'll walk you through and explain like what we found based on the analysis. Okay, so first I'm going to start with all facilities included. I'm not differentiating between different types of facilities. I just want to see whether this thing actually even worked, right? Before we look at different types of facilities. So when we look at the full sample, which is all the facilities included, what we see is that a transition to the informed push model actually led to significant decrease in the likelihood of stockouts. Okay, so what we see is in terms of effect sizes, this is about a 16% reduction in the likelihood of stockouts on average at last mile facilities. Okay, so this is a pretty significant improvement, 16% reduction in the likelihood of stockouts. So now I'm going to look at different types of health facilities and see where there is more benefits and where there is less benefits. So let me start with LMIS practices. So here what we see is the transition leads to about a 25% decrease in the likelihood of stockouts at facilities with less mature LMIS practices, compared to about only 12.5% reduction at facilities with more mature LMIS practices, right? So the benefits are roughly half as we go from facilities with less mature to more mature LMIS practices. And this is what we had predicted. So this actually supports our prediction that the transition would be more beneficial for facilities with less mature LMIS practices. Okay. Now let's look at road infrastructure. So here what we see is the transition leads to about 20% reduction in facilities with less developed road infrastructure compared to about 11% reduction in facilities with more developed road infrastructure. So again, this supports our theoretical prediction that the transition would be more beneficial for facilities with less developed road infrastructure. Okay. And then finally, what we also do is we look at the combinations of these two attributes. So we look at road infrastructure and LMIS practices in combination. And there, what we find is, by far, the largest benefits are observed in case of what we call as severely disadvantaged facilities. So these are facilities with less mature LMIS practices and less developed road infrastructure. So they have disadvantages on both dimensions, and that is where we see the largest benefits. And the effect is about a 30% reduction in the likelihood of stockouts. Right? So that's a huge reduction in terms of benefits. On the other hand, the least benefits are observed in case of facilities that are not disadvantaged. So these are facilities that have more mature practices and more developed road infrastructure. So in that case, it's about a less than 10% reduction in the likelihood of stockouts. Okay, so I'm gonna switch gears more to the domestic.
Yeah, before you said, okay, there is a 16% reduction in stockouts if you move to the push model from the full model,
Yeah.
right? But broadly, how does it compare to the cost of transitioning? Was there a cost involved? It's the cost benefit that you have to.
Absolutely, yes. So it's almost like you've seen my presentation. So that is the third research question I'm going to get to. Okay. So the way I'm doing this is, first I'm looking at the supply side benefits. So I'm showing you all the reductions in stockouts. Second research question, I'm going to look at how does this benefit customers, right? So what happens to their satisfaction, what happens to unplanned pregnancies, maternal deaths. I'm going to show you all those numbers. And then the third research question, I'm going to look at, okay, these are the benefits. This is actually the cost. What does the cost ratio look like? And where should we do what kinds of initiatives? Yeah, absolutely. So that is going to be the third piece. Yeah. Okay, so second research question, I'm going to focus on the demand side. Okay, so we are going to take the benefits in terms of reduction in stockouts, and I'm going to use that to estimate how is this going to benefit customers who want access to these contraceptives. Okay, so to understand the public health impact, what we do is, so again, SPA has another survey called client exit interviews. So as people exit the facilities, they actually ask them, how satisfied are you with the products that are available? How satisfied are you with the healthcare providers and so on? Okay, so we leverage that information, and we have information for 2 rounds, 2012-13 and 2015. Okay, So what does this survey tell us? It's focused on client satisfaction with products and services at last minute facilities. Okay. So this is all actual client data. Because we have 2 rounds of data, we do a pre and post study. And what we see is that the inform push model actually led to significant improvements in client satisfaction on average. Okay. But more importantly, the largest improvements were again observed in case of severely disadvantaged facilities. So this is the group that has less mature LMIS and less developed road infrastructure. Okay. So in that case, the improvement in client satisfaction was about 29%. Okay. And this has a lot of spillover benefits, because if you are satisfied with the client facility, health facility, you are more likely to go back again. You have trust in the health system. So there's a lot of spillover benefits on top of just getting the products you want. Okay, so in addition to client satisfaction, we also look at a lot of other public health metrics. Okay, so there is this tool called Reducing Stockouts Impact Calculator. So this is a pretty interesting tool. Anybody can access this. So if you go to the web and type this Reducing Stockouts Impact Calculator, what you will see is you can put in reduction in stockouts. So let's say today it is 30% and tomorrow it is 20%. So for each of these 30% and 20%, you can look at how that translates into health impacts. Okay, so and that is the tool that we actually leverage, because we can calculate how much stockouts are reducing. So we feed that data into this calculator, and then that tells us what are the public health benefits of reducing stockouts at last mile facilities. Okay, so that is the tool we leverage, and based on that we calculate the contraceptive prevalence rate, the number of unplanned pregnancies that are averted because you have access to contraceptives, and then also number of maternal and newborn deaths that were averted because of having more access to contraceptives. Okay? So from this analysis, what we see is for facilities with less mature LMIS practices and less developed road infrastructure, the contraceptive prevalence rate, so this is how many people are actually using within the population, that percentage actually increased by about 18%. So that's a pretty significant improvement. In terms of number of unplanned pregnancies that were averted, it's about 6,200 for every 100,000 women of reproductive age. Okay. And then the number of maternal and newborn deaths that were averted is about 145, again for every 100,000 women of reproductive age. Right. So essentially, what we are seeing is we can save 150 lives by having better stocked facilities at the last mile level. So the largest benefits again are observed in case of severely disadvantaged facilities. And then the benefits for other types of facilities are somewhere in between, just like we saw for the stockouts case. And then the least benefits are observed in case of facilities that are not disadvantaged. Okay. So essentially the main takeaway from here is that all the supply side benefits of the transition in terms of reduction in stockouts and the implications for different types of facilities also actually transfer over to the demand side in terms of public health impacts. Any questions before I move on? Okay, so the last piece is what Shrikar, you were asking about. So there is a cost benefit trade-off, right? So there is money to be invested. We're also seeing benefits in terms of reduction in stockouts. So given this trade-off and resource constraints in developing countries, which facilities should be prioritized for transitioning to the informed push model? So that is our final research question, and pretty much all our implications are going to come from answering this question. Okay. How are we doing on time?
I think it's 4 o'clock. I think we're good. We still have 30 minutes.
Okay.
35.
Okay, so just as a reminder, we already know the benefits. We calculated the reduction in the likelihood of stockouts, and we see that there is wide variation in terms of the benefits in terms of likelihood of stockouts, right? So this is something that we already calculated. So what I'm going to do now is I'm going to take this information, I'm going to expand on these insights by doing a cost-benefit analysis. Okay. So how do we define the cost-benefit ratio? So this is going to be the ratio of how much does it cost to transition a health facility from the pull model to the push model, and then divide by what is the change in the likelihood of stockouts that we already estimated from our analysis. Okay. So the main thing I'm going to do now is to calculate this cost for different types of health facilities. Okay. So how do we do this? It's actually not pretty easy to do. It's this took a lot of time for us. Okay, and we did leverage some ideas and data from prior studies that were done in this area. So what we do is to estimate the cost. So there is this paper, Lynch et al., that was published in 2020. It's actually a report, not a paper. So they developed this cost approximation approach. So we use that to develop estimates of cost of transition at each health facility within our sample. Okay. So the main idea here is actually pretty clever. So what they do is they progressively allocate costs from the national level to the regional level, region to districts, and then from districts to the last mile health facilities, right? Because when you do this kind of transition, it's not just impacting only the last mile. There might be other costs involved at the national level, regional level, and so on. Okay. So as an example, what they do is they estimate this modified regional cost. So what this does is think of costs incurred directly at the regional level. So I will account for that. On top of that, I also will account for the national cost, and that's allocated across different regional warehouses, right? So that's why you see the regional cost plus the national cost divided by 2, because that national warehouse is serving 2 different regional warehouses. Okay. So now we keep doing this for stage by stage. So if we get to the health facility level, the modified health facility cost is simply cost directly at the health facility level, plus I take the modified district cost and then divide by 3, because that district warehouse is actually serving 3 different health facilities. Okay, so this is how I allocate the entire supply chain cost to the last mile health facilities. Okay. Any questions on this? Yes.
So with the districts and the regional, it's not constant. Is it constant or it depends on wherever and how many regions the country has? How many regions?
Exactly. So this is all based on actual data. So some districts may serve 3 health facilities, some may serve 50. So in that case, you would divide by 50. Because that one district warehouse is serving 50 different health facilities. So yeah, we actually use their public health supply chain data to see which warehouse is serving which health facilities, and that's how we allocate the cost. Okay, so what they do is they estimate costs at the national level, and they also do random sampling at each level, regional, district, and health facilities, to get an estimate of the costs at the different levels of the supply chain. Okay, so we leverage that, and we develop estimates for the pull model at different levels of the supply chain. And similarly, we also do it for the informed push model, also at different levels. So now that we have the costs, we can calculate the cost-benefit ratios. Okay. So that is what is shown in this table. So what you see here is the cost-benefit ratio for different types of health facilities. Okay. So what we see from here is, so funding allocation toward transitioning to the informed push model are most cost-efficient for the severely disadvantaged facilities, right? So this is where you get the most for your investment, because again, so the numerator is the cost, denominator is the benefit. So the lower this number is, it is actually better, right? So most cost efficient for facilities that have less mature LMS practices and less developed road infrastructure. So for the other combinations, the cost efficiency is somewhere in between. And then facilities that are not disadvantaged, that's where it is actually least cost efficient, right? So if you're going to roll out this model, those are the facilities that should receive the last priority when it comes to implementation. Okay. So that's why one of our implications is that it is better to not prioritize such facilities for informed push transition. Okay, and then as I promised, I'm going to compare this to, you can do 1,000 other initiatives to also increase the last mile availability of health commodities, right? So what we do is, in our context, one obvious alternative is to just buy a computer, for example, right? So invest in enhancing the LMIS practices of health facilities. So how does that compare to doing a full-blown transition to the informed push model, right? So that is something that we compare. So again, for this, we had to collect data on the cost. So based on these sources, what we estimated was it's going to cost about $358 to invest to just improve LMIS practices at health facilities. So you're not changing the distribution strategy, you're simply enhancing the LMIS practices. Okay? And based on that, we can calculate the cost benefit ratios. Okay, so what does this tell us? Let's start with severely disadvantaged facilities. Okay, so if we just look at this row, the obvious temptation is to say, cost benefit ratio is lower for enhancing LMIS. So let's just buy a new computer and update LMIS daily rather than coming to a new distribution model, right? But this is where looking at a ratio can be misleading, right? Because once you unpack the ratio, what we see is, yes, it is more expensive to implement the push model, but it also offers significantly higher benefits compared to just improving LMIS practices, right? So in this case, what we would recommend is, if funding is not too tight, go for a full-blown transition to the informed push model rather than just focusing on improving LMIS practices. Okay. The results are actually very different for moderately disadvantaged facilities. So in this case, what we see is the benefits are actually roughly the same, but it is much more expensive to implement the informed push model. So in this case, we see no reason to do a full-blown transition to the informed push model. So here, you would rather invest in just enhance LMIS practices and not invest the additional money to go all the way to a new distribution model. Okay. Any questions on these two? Okay, so let me just show you the summary slide, and then I'll be happy to take questions. So essentially, like through all this rigorous analysis, what we see is that, so we can sort of segregate facilities into different types of facilities. And what we see is for facilities that are not disadvantaged, those should not be prioritized for informed push implementation. Okay. If you are moderately disadvantaged, so you are better off in one dimension, but you don't have, let's say, good road infrastructure. So those kinds of facilities, just enhance LMIS practices, don't do a full-blown transition to the informed push model. And then if you're a severely disadvantaged facility, go all in and do a full-blown transition rather than just enhancing the LMIS practices. Okay. And then the other implication that we have is that whatever benefits that we see on the supply side also transfer over in terms of public health impacts. Yes.
Yeah, so I know we are talking only about contraceptives, but do you have instances, if you're talking about countries, less developed countries, instances of theft of these in the last mile, and how is that? How are those instances in a push model versus a pull model?
I see. So I would say if it is due to theft, the effects probably would be similar, right? Because end of the day, when it is a theft, you're probably recording it as a demand. So I think the information would be pretty consistent across both these scenarios, because the logistics providers are only verifying what is on the cards. But if I say that there was a demand when there was no demand, there is no way for the third party to actually verify and say that's not actually true. Right? So theft probably would have similar effects.
Any
questions from the group?
And it can be on this project or anything related to public health. I'm open to questions. Yes.
How successful has that been thus far?
This implementation. So that's a good question. So the reason we did the study was that, and also some of the follow-up studies we have done. So the way these are implemented is like, because there is going to be political pushback, you typically cannot roll it out to one region because the other regions will be unhappy. And so the reason to do this kind of analysis is to give governments the tool to say, based on data, we see that these are the only regions where it's going to be beneficial, and these are the regions where it is a waste of public money, right? Otherwise, there's going to be a political pushback from the regions because every region wants in, and they're like, why are you leaving us out? So this is more to give them actually database tools to say, we actually can see that this is where it's going to be beneficial, and maybe here it's not going to be beneficial, right?
Is there any framework or regulation at multilateral organizations like United Nations or WHO, so that as we have seen in the first slide, that the developing nations, they have better access to healthcare and where they can use their technologies and their expertise to develop the healthcare and contraceptive facilities in some least developed nations.
Yeah.
By involving some stakeholders like governments, philanthropic organizations,
yeah,
and some think tanks.
Yeah, so that's a great question. So the way these supply chains work is, you're absolutely right, there is multiple players involved. And so typically the separation is, countries are very protective, rightfully so, of supply chain operations within their countries. So you won't see a US aid directly operating a health facility at the last mile. So those are done by the local governments. What multilateral organizations will do is they will help with, for example, training employees. So inventory management, training external organizations help. They will also help with procurement and until it gets to the national warehouse, right? But once it is inside the country, countries typically don't like multilateral organizations running their supply chains. So they won't give up that control. So there are places where they play in terms of training, in terms of providing, so it's called as technical support. So they will provide technical support, but the supply chain is still managed by people within the country.
And what if we have a combination of both the push and pull models, where the healthcare workers, they might be combined with the logistic supply providers, so to improve the last mile connectivity and to address the logistics issues.
So the push model here is exactly that, right? So the logistics providers are involved and they are taking care of inventory, and then the health workers are doing their job and providing healthcare to patients, right? In the pull model is where both of these roles are mixed. So the health worker is basically doing everything from inventory management to providing care to patients. So so this is already a hybrid model where both health workers and logistics providers.
Actually, I mean, they can use some innovative strategies like using some public places like places of public transportation or some gathering kind of events where they can distribute these kind of contraceptives or make awareness to people at remote places.
Yeah.
And they can even use some, if they are allotted some funding by some multilateral organizations or some philanthropic organizations, by using some of the advanced technologies like drones or some emergency workers to address the issue in some African countries or maybe in some war-prone areas.
Yeah.
So I feel it should be.
It's a great question. So it's not my work, but there is some work already happening, some research happening that is looking at, if I can use a drone versus if I'm a government, I can build roads to provide better access to health facilities. There's a study that looks at which one is actually more beneficial and which one is more cost effective. So yeah, so that is already being done. It's not my work, but somebody else is actually working on it.
Any other questions? Okay, let us give a big round of applause.
Thank you so much. Yeah, and again, thanks for taking the time and being here. I enjoyed the interactions and the questions. Thank you.